I'm Hetal Karsan. I'm the chair of medical education for United Digestive, and I'm here to talk about managing complications of primary biliary cholangitis and their impact on quality of life. Primary biliary cholangitis is an autoimmune cholestatic condition where the body's immune system attacks the small bile ducts within the liver. It's most commonly found in women, but it's actually becoming more found in males these days. But this immune attack just leads to chronic inflammation and fibrosis. And over time, that fibrosis eventually leads to cirrhosis. Interestingly, this disease used to be called primary biliary cirrhosis, PBC for primary biliary cirrhosis, since patients were diagnosed late and often cirrhotic at presentation. But now the disease is becoming more commonly diagnosed early in the course of disease, and the diagnosis is made much earlier. So it is important to call it primary biliary cholangitis. It's the same acronym, substituting the C for cholangitis instead of cirrhosis. It's important because patients don't want to be confused, don't want to think they have cirrhosis. And also, it's important to know that cholangitis can be treated. In fact, if patients respond to ursodeoxycholic acid, which is the first FDA-approved therapy for this condition, it was approved almost 30 years ago. They have a similar survival benefit if they respond to therapy and they're found early in the course of disease. So it's important to treat patients before they become cirrhotic. And of course, you want to confirm and talk to patients, make sure they're taking their medications. Not everyone takes medications. You got to take the appropriate dose, which is 13 to 15 milligrams per kilogram per day, and generally in 2 divided doses. The goals of medical therapy on PBC is actually really normalizing alkaline phosphatase as close as normal as can be, because when alkaline phosphatase is normalized, it improves prognosis and survival. So the goals of therapy are really getting close to having a normal alkaline phosphatase on therapy and a normal bilirubin. And normal means not 1.0, but less than 0.7. That has been shown to improve long-term prognosis. Once there is cirrhosis, we have to think about complications of portal hypertension, such as variceal hemorrhage, ascites, hepatocellular carcinoma, etc. And once you do have cirrhosis, early in the course, it's compensated, and those patients with compensated cirrhosis have a mean survival of 12 years. However, once someone develops an acute complication or any complication of cirrhosis, most commonly ascites occurs, there's a 2-year mean survival at that point in time. So it's important to recognize it early, and then you want to stop progression of disease if at all possible, or slow it down. It never surprises me that sometimes I have a patient who will have acute complication, such as variceal hemorrhage, and that can just spiral downwards with SBP, hepatorenal syndrome, multi-organ failure, and even death. So it's important to watch for complications carefully and watch when their disease decompensates. So getting back to cirrhosis, if a patient is cirrhotic, you want to get an EGD to screen for varices and take appropriate action, such as if they have large varices with red whale signs. Band ligation has been shown to prevent rebleeding. Beta blockers also work. And in fact, there's a recent study using carvedilol has been shown in small varices to delay the progression of ascites and may even improve mortality. So that's important to act early on that. As well as variceal hemorrhage, you got to remember these patients are at increased risk for hepatocellular carcinoma. So we should check alpha-fetoprotein and ultrasound every 6 months. Not all patients can get an ultrasound. It may not be as accurate in patients living with obesity, or maybe they have coexisting mast, so they may have to do cross-sectional imaging. Or if there's a lesion found, you may need cross-sectional or IV contrast imaging to clarify if they have a hepatocellular carcinoma or worrisome lesion. When patients do have cirrhosis, it's important to limit their sodium intake, and generally recommended to try to keep within 2,000 milligrams sodium daily, especially if they're developing ascites, to keep a fluid balance in order. I mean, you don't want to restrict their protein. Sometimes patients are told to restrict protein, but that is not the case with cirrhosis. That can play into sarcopenia, which can be another devastating complication, and reduce survival. So you want to increase protein intake, make sure they're getting all the nutrients they need. Importantly, you want to avoid eating oysters or raw oysters or uncooked shellfish, there's a risk for Vibrio infection, which can be very deadly and fatal. So want to explain to patients what a proper diet entails. With any cholestatic liver disease, such as PBC, it's important to check for fat-soluble vitamin deficiency. That includes vitamin A, D, E, and K. And vitamin A is important to check because if you have a deficiency of that, that can cause night blindness and especially troublesome to patients who are driving at night. And that can be very hazardous to patients and others on the road. Vitamin D is important to check. Seems like everybody's low on vitamin D these days, but you need to replete as needed. Vitamin D deficiency can lead to osteoporosis. And so you want to make sure patients are getting plenty of calcium and vitamin D in their diets. Along with all of this and osteoporosis, you want to check bone densitometry. That should be checked and treated as needed, and encourage patients to do weight-bearing exercises to maintain strength, to reduce complications such as osteoporosis and sarcopenia, which we discussed. What I do is I tell patients, hey, what activity do you enjoy? It has really been what I've noticed is that patients will tell you if they enjoy an activity, they're more likely to do it. That helps their quality of life, and also make sure they exercise more and reduce their risk of sarcopenia and also osteoporosis. So weight-bearing exercises of something they enjoy should be encouraged. The last thing you want to do is have someone who may have osteoporosis and then have a fall and get a hip fracture or some other vertebral fracture. And all of a sudden they can, again, dwindle and spiral downhill and be bedbound, get sarcopenic, and then potentially even fall off a liver transplant list. And it can be just deadly. So it's important to be cognizant of bone fractures and high risk in these patients. Fatigue and pruritus are the most common symptoms of PBC. We're not so good at improving fatigue in PBC, but if we can make patients feel better, that can help fatigue. Don't forget that patients with PBC often have thyroid abnormalities, so checking levels and treating as appropriate can help their fatigue as well. So that helps their quality of life. Pruritus is the second most common symptom, and it's been shown that surveys have been done, and providers are not so good at asking about pruritus in particular. It seems like we underestimate how much pruritus means to patients. And there are new options and medications now available that can help treat pruritus. So really it's important to ask about it, and should be commonplace to ask about pruritus in particular, because patients may not come out and tell you about it. I mean, I've had patients tell me they avoid going out in public because they don't want to see others scratching or see others witnessing them scratching themselves. So there's patients who've told me they sat in the back row of a church, so they don't want people seeing them scratching themselves. They don't wear short sleeves, especially in the summertime, due to excoriations they can have. I tell patients don't forget to trim their fingernails to reduce excoriations. You can also do moisturizers, fragrance-free soaps and laundry detergents can help, and cotton fabrics are better. Avoiding too much elastic can help. Elastic seems to cause pruritus right around where waistbands and so forth have elastic and can cause issues there with pruritus. Remember, the pruritus, especially at night, can be troublesome, and that can impair sleeping. And the further someone has insomnia due to pruritus, the further fatigue they're going to get into. It becomes a really vicious cycle. Lastly, I think emotional support is very important. Obviously, talking to patients, reassuring them about their disease, that we can take steps to improve their condition, and then there is hope and light at the end of the tunnel. It's very important to tell patients about that. Also, I do encourage them to look at online support groups specifically dedicated to PBC. There's a lot of online support groups which are very good and can help patients talk to other patients who feel the same way they do, and that can help improve their quality of life. So those are little tips that I think hopefully it can help you in managing your patients with primary biliary cholangitis. I want to thank you for listening, and please visit the GAP website or the GAP ACE app for more information. Thank you very much.